Speaker is already here. He is anxious. Yeah, our next speaker is Dr. John Allen, and he's, I didn't mention it, but we have at least two prolific scientific writers in hand with our Dr. Johns. And I know I've read some of John Allen's work, and he's got this sometimes subtle sense of humor. I think he excites our neurons and helps us to understand the point that he's making. And in other words, he is not that much into hype, but I want to give an instance here. I noticed that he was delving into the term client-centered therapy. This is a term that's more frequently used in the past. And he notes that how we now tout therapies with acronyms like CBT, DBT, TFT, DIT, EFT, TPP, MBT, ERP, SIT, IPT, PCT, and he protested because he longs for the days of POT. It's not what you think, Carl. That's plain old therapy. But Dr. Allen, he's got a professional focus on trauma, depression, and mentalizing. And as many of you know, he came to speak at one of our monthly BPD family support meetings in Houston, and it was just serendipitous, but they moved us to this fireside room, which is very large, and it turns out it was our largest meeting that we had ever held in our 9-year history. And I think I remember from that is how he demystified psychotherapy, which sounds pretty high powered, but he said, no, basically it's just common sense. So that's something stuck with me. So today Dr. Allen's going to give us his insight into mentalizing, and if I'm mentalizing correctly, it's time for me to sit down and you take over. Thank you.
Yes, you mentalized my eagerness. Thanks, Jim. And I'm really glad and fortunate, I'm honored to be here and honored to follow John Oldham, because I think my talk is going to dovetail with his, and basically I'm going to piggyback on some of what he said. I'm going to focus really on the environmental side, but the genetic and environmental are inextricable, because by our natures we have a profound influence on our environment and vice versa. So I'll be putting these together, but I'm mainly going to talk about mentalizing, and I want to start by asking you a question. So imagine, okay, you're all sitting there, and imagine suddenly I start getting jittery and run out of the room. So what goes on in your mind? Anybody?
You're nervous.
I'm nervous. What other thoughts might you have?
Plane flat.
Got to get out of here, yes. This is semi-true, but it's not until...
It's called on an emergency.
Yeah, called on an emergency. Bathroom. Yes, this is probably the highest probability. Too much coffee, yes. Okay, so the point is that I'm doing something that is kind of out of what you would expect, and you cannot help thinking about why. What was going on inside me? Okay, now let's say you're sitting there right now, and all of a sudden you start to feel jittery and you notice your heart racing. What do you start thinking? I'm nervous. And then what, so let's say you say, yeah, I'm nervous. Then what goes on in your mind after that idea? Well, yes, you could, right? Got to get out of here, right? How am I going to deal with this? Then you might start wondering, why am I so nervous? So I'm making these examples because this is all we mean by mentalizing. And mentalizing is very confusing because it's an esoteric word, but it really refers to something that basic human nature to do it. But what we've learned is that we all could learn to do it better. And boy, you talk about practice and time and work over time, and actually a lot of what we think about in psychotherapy is practicing this very human skill that we all could do better, and a lot can go wrong with it, which is why it's there. So I just wanted to start there. Basically, you all do mentalizing, and we've made the claim about therapists all are engaged in mentalizing, but John Oldham made a very important point. He said, yes, we all do mentalizing when we are doing our job. So that's the caveat. Parents mentalize, you could say, yes, when they are doing their job. And then we need to understand what gets in the way of that job. And one of the things that gets in the way of it, everybody in this room, I assume, knows what it's like to just lose it with a child for various reasons. So that we're all vulnerable to losing it, and that's what we're working on. So I want to give a little context for my interest in mentalizing, how that happened. I've been interested in attachment and trauma for a long time. And by the way, I'm going to talk a lot about trauma, but I want you to think differently about trauma by the time I'm finished talking about it. We think of trauma, we think of combat, we think of rape, we think of abuse, we think of neglect. I want to get to the core of it that's much more pervasive than that. So it's a broad use of the idea of trauma. So that's another goal I have. But in any case, so I was interested in attachment and trauma. And like manna from heaven, Peter Fonagy drops out of the sky into Topeka, Kansas. He was brought to help us reshape research. This, for me, I didn't know anything about Peter Fonagy. This was just pure dumb luck that he shows up. So he and I were interested, we shared interest in attachment and trauma and research, and he was interested in mentalizing, which I knew nothing about. But I got very interested in it because mentalizing has to do with how we develop a mind and how the mind works. What psychologist wouldn't be interested in that? So to me that was fascinating. Now, as you know, and John just talked about it, you probably knew about it, Peter Fonagy and Anthony Bateman have developed a treatment for BPD called Memoization-Based Treatment, one of those acronyms, okay. So, but we worked and we got interested in, a few of us got interested in it. Ephraim Bleiberg was one, so we had a British psychologist, Tony Haslam-Hopwood, and myself, we got interested in mentalizing and how we might start using it in treatment. And so we thought, well, let's do a group for patients on mentalizing in the Professionals in Crisis program at Menninger. But you see, this was not a program for BPD. This was a program for patients with all kinds of problems, including personality disorders, mood, anxiety, the whole 9 yards. So we weren't thinking about BPD, we were just thinking about how could we use mentalizing in treatment. And we started with something quite modest, which was, well, we're thinking that treatment requires mentalizing and that we need to be mentalizing ourselves and engage you in mentalizing. And so we want to do this group so we can explain that to you so you know what we're trying to do in treatment. And then we realized, wait a minute, it's not just educating you about how we think about treatment. Mentalizing is a good thing to do. We all need to do it. And so that's where we've come now. This is a good idea. Now I'm glad Jim mentioned the idea about common sense, because I had this experience in a group not unlike this. I gave a whole talk on trauma, and this father stands up back of the room and he says, "Doctor, isn't everything you just said, isn't that just common sense?" And I said, "You've understood me perfectly." I thought that was wonderful, that the common sense came through. Now there is a problem with common sense. It was common sense that the earth was flat. So the thing is about common sense, it's really nice when you have science that supports it. So, and I think that's really where we are with this whole idea of mentalizing. And I'll get to plain old therapy in a moment. And I confess, I do like the acronym. I talked about it in Holland. Was the first time I went really public with pot. Went over very well. They're actually having some trouble over there with it, but with marijuana. Okay, so I think I'm ready to start giving my talk. One other thing I want to cue you into, validation is so important. Now think about validation mentalizing. They're very closely related terms. The other thing is, I have my email address, well, you got it on your handout. If you'd like a copy of these slides, email me, and I can also send you some articles, some brief articles on attachment and mentalizing, if you're interested. So here's my whole talk. Basically, that a core problem for persons with BPD is emotional turmoil related to insecurity and instability in close attachment relationships. And John has done a masterful job of letting you know about the biological heritable component to that problem, what the individual brings to it. Our most potent means of regulating emotional distress is contact with a person with whom we are securely attached. This is a bold statement, and I'm going to emphasize more about it. And this is, by the way, what we're teaching patients. We establish secure attachment relationships through the activity of mentalizing. This is how we do it. This is how we form attachment relationships, secure attachment relationships. Mentalizing is at the core of this process. And then another principle is that mentalizing begets mentalizing, both in development and throughout life. So to go through, this should be later in the talk, but basically a lot of patients say, great, I'm understanding this mentalizing, I'm doing it, I know how to do it, I'm working at it here, but how do I get my spouse to mentalize? Now, we have only one answer to that: mentalize. If you can stay in that mindset, you're more likely to you might say, entice the other person into that mindset. You can't make somebody mentalize. This is what drives us all nuts, and how we drive each other nuts, which we do for a time. Okay, so that's basically what I'm going to say, so the rest is detail. We're going to talk about mentalizing at some length and then attachment at some length. So defining mentalizing, there are lots of definitions. I'm not going to go through this. You've got it in your handout. But I do say Peter Fonagy's phrase, holding mind in mind, I think is a great phrase. That you're being mindful of your mind is another thing I'm going to talk about, because I want to mention mindfulness. But we've already talked about it at the very outset. Basically, it's a sense of connection with what's going on inside yourself and other people. This is a diagram we use for patients. Basically, the territory of mentalizing is being aware of thoughts and feelings in yourself and other people. It's a lot like empathy. Empathy, if somebody says, look, I just don't get it, I say, just think empathy. But just think, add empathy for yourself. So it's empathy, and if you include empathy for yourself, sensitivity to what's going on inside yourself and other people. So it's not that complicated. We just have this weird word for it. I did call up the Oxford English Dictionary when we wrote the book Mentalizing in Clinical Practice. And Peter Fonagy was vindicated because he said I kept accusing him of using a neologism. And actually the word is 2 centuries old, and it's been in the Oxford for a century. So but it's a rare word, and if you go into a bookstore and look in the dictionary, often you won't find it. So anyway, the Oxford definition is give a mental quality to. So you were doing that. If I said, if I ran out of the room, you're not just looking at the action, you're giving it some kind of mental context, that's the point. Or to picture in the mind, or cultivate mentally. I like that one for us, cultivate mentally, because that's what we're aspiring to do with psychotherapy. And of course, I might mention that medication is going to help mentalizing, because if you're affectively, dysregulated, anything that helps with that is going to help mentalizing. This was actually used in the French psychoanalytic literature for the last half of the last century, but it was brought into the English professional literature simultaneously in 2 ways. One, the problem with mentalizing was seen to be the core of the problem with autism. Autism would be the extreme example of problems with mentalizing. But Peter Fonagy realized, yes, but other people may have kind of transient difficulties with mentalizing. You could say this would be extreme, but momentarily autistic. I can own being at least momentarily autistic. My wife would confirm that. So in and out of this sort of lack of attunement to what's going on with yourself and other people. So Peter then applied that to the development and treatment of BPD. I'm going to tell you a story about Anthony before I forget it. Anthony Bateman is really the main driver of the mentalization-based treatment program. And Anthony is a very unflappable guy, just rock solid. But he tells this story about being with a patient with BPD who got him so riled up, he said he had to leave the room, ask the patient to see, said, I can't stand this, please wait here. Leave the room and go out and talk to his receptionist for a while, calm down so he could go back into the room and resume mentalizing. So if Anthony Bateman can lose it, we're all entitled to lose it, and the fact is we all do lose it. So, but when we started to do this here at Menninger, working with a wide range of patients, what we realized is that this problem in mentalizing is not specific to people with BPD. Imagine substance abuse and what a mess that makes of mentalizing. Depression, anxiety. So this, it really cuts across lots of psychiatric disorders. And then we came to conclude that mentalizing is actually a common factor in psychotherapy. The slide John showed with the array of treatments for BPD, you could do that with a whole bunch of psychiatric conditions, that there seem to be, all these things work. So what is it that's in common to them? This idea is not, it's not a new question actually. Jerome Frank famously said in 1961, he said, so all these things work. Must be something they have in common. And we have made the strong claim that it's mentalizing. And actually, what I would say is that, yes, DBT is great because it promotes mentalizing. And it requires mentalizing. You cannot use DBT skills without mentalizing. Validation entails mentalizing. So just trying to take over the world, that's all it boils down to that. What I don't like about mentalizing is that other people don't like it. The word's too weird, it's off-putting, it's jargon. And to make it worse, the president of our clinic, Ian Aiken, doesn't like it. So that's a problem. So the other, more substantively, what I don't like about it, it's too mental. It seems too intellectual, like you know, it's all to do up here, whereas actually it's emotion that really concerns that. And you see that in John's talk is very clear. So really, the basic trick, it's more than a trick, challenge, is to be able to mentalize when you're in an emotional state and to understand emotion. And when we thought of me running out of the room, yeah, it could be the bladder, the prostate, yes, but we thought of emotion first, of anxiety, something urgent. So really that's the thing that is misleading. The other thing is a lot of mentalizing, we emphasize thinking when we do when we talk about mentalizing, but it's thinking in the context of emotional states. And the thing is, there's also this kind of intuitive gut level mentalizing that's very important. You know, somebody comes to you and they're really distressed or upset, automatically, you know, you change your demeanor, your voice tone, your posture, you adapt to this automatically. It's kind of intuitive sensitivity to mental states and other people. So it's not all cognitive, I guess, is the main thing. And it's a very broad concept, which is partly problematic. It's good, though, I think, to have a word that captures attention, so people will actually pay attention to it. And it gets us in the right ballpark. This seems nitpicking, but I think we need a verb. Mentalization, mindfulness, psychological mindedness, these are all good concepts, but we need a verb because it's something we want people to do. basically we are advocating mentalize. So it's good to have that. There is not an exact synonym. Please take that on faith. There are different aspects of mentalizing already. I talked about mentalizing thoughts versus mentalizing feelings, trying to understand what a person is thinking or what you're thinking versus what they're feeling. You're mentalizing yourself, others. We can mentalize with regard to behavior, kind of react to what we see. So somebody starts frowning. Here's a problem that's common. So as a therapist, I start frowning, usually because I'm puzzled. Okay, so the patient sees the frown and says, I know it, you hate me, you're fed up with me, you're furious at me. It's responding to the behavior. So that's the behavioral, the external aspect. But there's the internal aspect of trying to understand what's going on inside that person, what that behavior means. A very common problem with borderline disorder is over-interpreting behavior. I'll get to that in a moment, and Carla, I think, is going to talk about that this afternoon. So, impairments of mentalizing. There are two basic ways, besides misuse. I mean, you could be a psychopath in some ways could be a very good mentalizer, exploit and manipulate people. This is not what we advocate for mentalizing. So besides that, there are two impairments. One is basically not doing it. You can be very concrete. Well, the reason I'm depressed is it's too hot in here. You know, it's not psychological. Be very concrete, or be indifferent to it. I don't care how other people feel about what I do. We do run into this. And you can be averse to it, not wanting to do it, afraid to do it. I'll get back to that in a moment. It's the term mind blindness that I like for that. Now, going a bit over the top here, you can be too imaginative, read too much into things in a distorted way. There's imagination gone wild. And here we have a couple of technical terms. Hypermentalizing, Carla will talk about this afternoon, but we have one that we introduced in our book, Mentalizing in Clinical Practice, excrementalizing. Pardon the vulgarity, but it does have a bit of a punch to it. I got to tell you how this, and I can even disown it because it was our daughter Yvonne who came up with it. She's a speech and language therapist, works with kids with autism. So we went to this movie Sideways. It's about a kind of drunken debacle in Napa Valley. And there's this guy who's trying to get his book published. I can identify with that. He's having trouble. The publisher, you know, he can't find a publisher. Eventually his agent dumps him. So he's with his chum sitting on a beach looking out at the water, and he says, I feel so insignificant. I'm like a thumbprint on the window of a skyscraper. And then he says, no, I'm like a smudge of excrement on a piece of tissue floating out into the ocean amongst millions of tons of sewage. So, okay, so that's a pleasant image, yes? So we're driving back, and Yvonne happened to be with us, and we were talking about that, and she said, he was excrementalizing. So that's where excrementalizing comes from. The definition is, yes, you're mentalizing, but you're doing a crappy job. So I mean, and this is, I mean, it's good that we can laugh about this, but this is our problem, you see, that and, you know, hypermentalizing is, but this got into the glossary of our book. It's in the index, too, but they actually put the wrong page, so I think somebody was ambivalent about that. Anyway, so mentalizing, you do need to be imaginative, but it needs to, your imagination needs to be grounded. So what we do in patient education groups, we could do it in this group, but we don't have time. But it's really interesting, is we engage patients in mentalizing exercise. We explain what we mean by mentalizing, and they say, okay, let's practice doing it. Let's play with it. So we say, okay, we'd like you to think of a visual image that would capture something or symbolize what you're struggling with in treatment. So they come up with them, and we write them on the board. One of my favorite ones is, I'm trying to walk up a down escalator. Beautiful image for dealing with depression. So we write these images on the board. And then we say, okay, anybody in the group, pick one that intrigues you, and let's see what the image might tell us about the person's struggle in treatment. And so we discuss them. And we ask the person who gave the image to stay silent while we discuss it. And we don't let people interview the person who gave the image. And then when we finished with the discussion, then we ask the person who gave the image what fit, what doesn't fit. So they engage in mentalizing, but there's a groundedness to it because partly we have the person who created it there. So this is the obvious advice we give. Well, you're worried about what somebody's thinking, check it out, so we check it out in the group. But the interesting thing in these groups is, A, the person who gives the image often is deeply touched by the extent of interest and understanding that other people show. And of course these people know each other to varying degrees, which really helps them. But the other thing that's impressive is in the group, the quality of mentalizing is amazing. It's humbling to us. I mean, it's not like, well, give us the image and we'll tell you what it means. No. Let's think about it as a group, as a community. And so it really illustrates the power of the therapeutic community when you see the mentalizing capacity of the group, when you get the group into a kind of mentalizing frame of mind. One would love to see the same thing in a family, sit around talking about dreams, with that kind of interest in each other and to play with it. So this is part of what we do. I love this example. Story told by the mother of a 5-year-old girl. Child had taken a stethoscope out of her mother's doctor bag, playing with it. She put the stethoscope to her ears. Her mother thought proudly, she seems interested in medicine. Maybe she'll grow up and become a doctor like me. The little girl put the listening end of the stethoscope up to her mouth and exclaimed, "Welcome to McDonald's." Perfect example of a mentalizing glitch. The point is, we do this all the time. And the last thing that I want to imply here is that we should be spot on with mentalizing all the time. It's absurd. This is more common. But the point is that what we do need to do is make an effort to do it. So we get in sync, out of sync, in sync, out of sync. The idea is getting out of sync is perfectly natural. It's going to happen to all of us, but the effort to get back in sync is what makes all the difference. Now, I do want to talk about mindfulness because it's a terrifically powerful, venerable, far more than anything else in this field, thing that people have been interested in for millennia and know a ton about, and is an enormously powerful intervention. So a reasonable question is how these two terms, mentalizing and mindfulness, differ. So I think the way we need to think about this is that this is just amazing that you have this relatively new, that is since psychoanalysis started, idea about mentalizing, which comes out of psychoanalysis and developmental research, attachment, trauma, and so forth. And you have this other tradition coming out of philosophy, ethics, and spirituality, and they do converge. I think of mentalizing in part as mindfulness of mind. And the remarkable thing is both of these, Jim mentioned this at the outset, are ways of contending with suffering. And so I think it's just wonderful that you see things converge, and I'm going to give another example that relates to what John was talking about in a minute. Now, so basically, if we had one piece of advice, it would be keep yourself in the mentalizing stance. And by the mentalizing stance, if you think about that group, this is what we're trying to promote. And a kind of inquisitive, curious attitude, open-minded attitude about what's going on inside yourself and other people. Anthony Bateman uses the idea of not knowing, and he says to therapists, cleverness is a cardinal sin. That basically the therapist is not an expert on that patient's mind, just as the parent is not an expert on the child's mind, but rather the parent or the therapist is interested in the child's mind, tries to understand, shares his or her understanding with the other person, and then the other person responds to that. So it's kind of a dance of getting connected that requires both people. Now, I think there's another thing that we neglect way too much, and that is the ethical dimension of mentalizing. And this is one of the reasons I like mindfulness, because it brings the ethical, spiritual dimension right to the fore. But we cannot set this aside. That when we're talking about mentalizing, we're talking about mentalizing with a kind of attitude toward the other person, which is interest, caring, goodwill, compassion, call it a spade, love, actually. This is what we are talking about here. So I'm interested in plain old therapy, which I think comes down to mentalizing in the context of attachment relationships. It occurred to me last night when I was talking about this, we should think about plain old parenting. I mean, you know, it's not complicated. It's difficult, but it's not complicated. And I think it really comes down to this, a certain kind of mentalizing in a kind of ethical context. And see, in our patient groups and in our clinic, I think this is really important because we're trying to create a therapeutic community which has an ethical foundation that is promoting this concern, interest, and caring, compassion in conjunction with trying to understand. So that's what makes the community therapeutic. And it gets less therapeutic when something gets in the way of that kind of ethos, would be another word. So we could think of a family ethos, a community ethos. So I think this is a hugely important part of it. So I'm going to skip this slide and just use this one. We think about mindfulness. The beauty of this is it really focuses on what you're paying attention to. So if you're being mindful, you want to be attentive to whatever it is that's before you. So you could be mindful of your breath or a flower. We're interested in encouraging people to be mindful of what's going on inside themselves and other people. Now, mentalizing is more complicated than that because it's not only paying attention to what's going on, but also trying to understand it. You think about psychotherapy, you're trying to understand, okay, yes, now I'm tuned in to the fact that I'm getting angry or that I'm feeling shame or I'm anxious. Okay, but what's it about? What's happened here that relates to this? And then we think developmentally, well, have you felt this before? Is this an old feeling? Well, where did that come from? And a lot of the mentalizing has to do with what's the relationship context in which you're feeling frustrated, angry, frightened, ashamed, and so forth. So that's the mentalizing piece. And this, by the way, to go back to John's talk, the mentalizing, a lot of the brain is involved in mentalizing. It's very complicated. But at the fulcrum of it is the medial prefrontal cortex, right up here. So you saw this tension between emotion, which tends to shut off, and it's like, so let me just say, mentalizing is the brakes. These are the brakes. This is what we're trying to engage the prefrontal cortex in regulating that affect. So we could just say we're the faulty brakes or brake repairmen. How about that? So there is overlap between mentalizing and mindfulness, and both of these, this is really a crucial and somewhat subtle point, is that you need to be aware in mentalizing that what's going on in your mind does not correspond to what's going on in reality necessarily. So the patient sees my frown, which has to do with puzzlement, or maybe even frustration with myself and my own inability to do something that's helpful. The patient is convinced this has to do with my dislike of him. So this is a loss of mentalizing. To gain mentalizing, the patient needs to say, okay, I am thinking and feeling that you're put out with me, but this is not necessarily what's going on in your head. That's the move into mentalizing. My colleague, Tom Ellis, psychologist, across the hall from me had a big sign in his office, "Don't believe everything you think." He's a CBT guy. This is the crux of mentalizing. Don't believe everything you think. I mean, if we could simply follow that, we would get out of a lot of trouble. And again, Carla Sharp was going to talk about this, reading too much into what's going on in others' minds. And she says, if we could just get people to kind of back off that into being, okay, I don't know. This is what's going on in my head. It's not the same as what's going on in your head. This is common sense, simple, but difficult to do, especially in an emotional state. So what gets in the way? Strong emotions, mainly. You get that emotional part of the brain going, and it tends to put out the brakes, and the brakes aren't all that well working anyway. So this is a double whammy, as John said. And defensiveness. Sometimes we don't want to know what's going on in somebody else's mind. You don't want to know if somebody, yes, indeed, is really fed up with you. You don't want to know about things that you think and feel that if you become aware, you feel very ashamed of or very self-critical of. So we tend to shut off mentalizing in a defensive way, and then, as I said, indifference. So now to attachment. What time am I supposed to stop?
Oh, tomorrow sometime.
I'll bet it's 15 minutes, is that right?
You actually have about 17 or 18, depends on whether you want to
Boy.
have questions or not.
Yeah, well, I have failed to mentalize, and I thought, gosh, I got plenty of time to get through this, but I don't. So I'm gonna have to.
We could have people sending questions.
Yeah.
If we already are going to handle some on the website.
Yeah.
So it's your
Okay,
choice.
I'll filibuster then. That way, the worst thing is, you can't answer people's questions, and so I'll avoid that. I do want to talk about this study. It's a terrific study by a University of Virginia psychologist. She got married couples who were satisfied, threatened the woman with shock. They did shock them sometimes. And the partner was there. And in some conditions, they could hold their partner's hand, they could hold the experimenter hand, the stranger, or no one's hand. And he did brain scan while people were under this condition of threat and looked at what difference does it make if you're holding somebody's hand and whose hand it is. And basically what they found is that there was the lowest level of brain activation when they were holding their partner's hand, and then somewhat lower when they were holding the stranger's hand, and the highest levels holding no one's hand. And the brain activation, there were two facets of it. One was the emotional arousal, and the other was the brakes, that is, the working hard to put on the prefrontal brakes to control the emotion. So you're holding a trusted figure's hand, and lo and behold, the whole thing is not a problem. You're not getting the surge of emotion, and you don't have to engage in all that regulation. Now, Cohn makes a very powerful point, which I use, that this is the most efficient, powerful way of regulating emotion, is being proximate with somebody you trust. There's another thing, like, you can put people at the bottom of a hill, and with a backpack on. You have them alone, you estimate the grade of the hill. Just have a friend with them who's going to climb with them, estimate the grade of the hill, and they estimate, the grade is higher when they're alone. I mean, there's just something, we're a social species, and our safety depends on connection with trusted others. It's obvious stuff, but it's really pretty potent when you see this in the brain. So this Cohn makes the point that, okay, we got all these treatments like CBT that work this thing here, work this thing. DBT, work this thing. But really, if we could be close to someone we trust, you don't have to do all that work. So what I take from this is why we work on attachment relationships. That the treatment really needs fundamentally to be directed towards strengthening attachment relationships. And I spent my life mostly as an individual psychotherapist, although I do these groups, And you think, well, it's too late now. But honestly, thank God for the family therapist. Because this, and I now really appreciate this working in this clinic. If we didn't have family therapy, whoa, this would be a tough road. The family therapy work, as you know, is really challenging and difficult. But the crucial thing is to work on improving mentalizing, which relates to attachment security in the person's key relationships. We practice this with therapists, we practice this with peers here, but it's really the person's key relationships and, of course, developing the relationships that's so crucial. So I want to see if I can quickly, I have to skip all this to make, oh, gosh, I hate skipping that stuff. This is what I want to get to. The mentalizing begets mentalizing point. This is work that Peter Fonagy did, and it is amazing. So you interview a parent. This started with moms. Moms when they were pregnant with their first child. They interview the moms about their thoughts and feelings about their attachments growing up, their relationships with their parents. An hour-long interview, pretty stressful. I've been interviewed, I started crying in the middle of the interview. I mean, it's very powerful stuff to, get a sense of how the person is able to mentalize, in fact, about their attachment history. They can really think about it, give emotionally convincing accounts of it, coherent accounts of it, and so forth. So you've got the parental security in relation to their own attachment history coupled with their ability to mentalize about it. And by the way, you can be secure in this interview even if you've had a pretty tough, troubled development in your family. The security has to do with comfort with attachment, with being able to talk about it in an emotionally convincing and coherent way. Okay, now here's the amazing thing. 1 hour interview with a pregnant mom. Then, a year after she's given birth to the infant, you put the infant in a laboratory situation that allows you to measure the infant's security with the parent. Basically, in the lab, the infant is, it's a playroom with toys. The mom is instructed to come and go. Sometimes the infant's left with a stranger, sometimes left alone. And you want to see what happens when the infant, when the mom comes back and you have the reunion. The securely attached infant comes to the mom for comfort. The mom provides comfort by picking up the infant, tuning into the infant's distress, and comforted, the infant returns to play. I just want to briefly link this to John's talk because there are two issues in attachment and development. Broadly, we need to be able to relate to other people, and we need to be independent and on our own. These are the two fundamental dimensions of our development. Relatedness and autonomy and self-definition, right there in your talk. The thing is that these two are synergistic. This is not common sense for a lot of people. That is, the way to be most effectively autonomous is to be able to depend emotionally on other people. This is something that we preach to patients because they tend to think, the best way is use your skills, make it on your own. Well, yeah, you could do that to a point, but when it hits the fan, you're really out of luck. And a lot of people come here because they've tried so hard to manage on their own, and they can't when stress gets overwhelming. So that was a bit of a tangent, but the point is that this goes together. So the securely attached infant basically relates to, depends on the mom, and then goes back to play. That's how these two, exploration and dependence, go hand in hand. But this is pretty amazing, that you could predict from a 1 hour interview what's going to happen 18 months later in a 20-minute lab situation. This is like, nobody in their right mind would try to make that prediction. So it works. Then the question is, how do you get from the parent's interview to the child's behavior? mentalizing. What else? What the research shows is that in that interim, these parents have been mentalizing with these infants. And it only makes sense, because why would an infant go for comfort to a parent who is not mentalizing? So this is why we're getting mentalizing going. The icing on this cake is that these infants who are securely attached and who have this history of mentalizing are more able to mentalize. They're more empathic with their peers. They can use emotion language. They're more imaginative in their play, and so forth. So this is the basis of POT, the therapy kind. That this is the principle that I think really runs through parenting, through love relationships, through therapy, is that we need to engage in these mentalizing interactions that then create a relationship that has the capacity to be the most potent regulator of distress. Nobody comes to this clinic if they're not in major distress. So this is essentially what we're about here. And of course, this can go wrong here with parental attachment insecurity, non-mentalizing interactions. And you get the reverse cascade. And remember John's points about what the infant or child brings to this interaction. Because as a parent, I can say that I've been driven into a frenzy more than once, lose mentalizing. And, you know, it was my kid. Now I gotta, here's, this is what I think, this is what I meant about trauma. That this is what is traumatizing potentially, is this combination of being in unbearable emotional states without mentalizing. Now mind you, if the infant or child is so riled up, you can be mentalizing, but they cannot experience it because their mentalizing capacity is shut off. But the best you can do is be mentalizing. And I brought up Anthony Bateman because sometimes you just have to walk away from the situation and calm down. If Anthony Bateman has to do it, believe me. Okay, then we've got a context, and we have, you know, always this issue of blaming parents. John talked about it's a pervasive issue. And, you know, we can't absolve ourselves from responsibility either. You know, we do things that are just not good, and it's not all the kid, in my case. But what we have to do is take a broad view here. What does the parent need to provide this secure mentalizing environment? What does the parent need? What's the answer from what I've said? Secure attachment. Exactly. This is what we need to function in this way. And so what we see is when the family system is stressed, not by just by the child, problems in the family, problems in the marriage, broader social context, lack of support, you know, financial strain, all of these things, illness, general medical illness, psychiatric illness, all of these things impinge on our ability to do what is an ideal. That is to stay in this mentalizing stance that enables us to regulate emotion. So we need to take a very broad view, and as this research that Fonagy and others have done, these are intergenerational issues, and part of the intergenerational process that John talked about is the biology that is inherited. But again, the environment and the biology are like this. The one affects the other. It's a two-way street, and we can affect that. So this is my last slide. Basically, it's a dyad. It's a humbling thing for me as a therapist to take this view because we're in the same boat. It puts us right in the same boat. Parents, therapists, spouses. If the challenge is to mentalize for the sake of security and trust in relationships, we both bring something to it, and we both have our history of varying degrees of trauma in this very broad sense of being alone in pain, psychologically alone in pain. So abuse and neglect and assault, these are extreme versions of this, but it's pervasive being alone in pain. So if we have, a history of that, and then in the moment, we're feeling threatened or insecure and so forth, we're emotionally aroused, we're going to have trouble doing this. So it's two people in a room in therapy needing to do this, or a group in a room, or several people in a family who are all bringing their history of emotion regulation and attachment security and insecurity, trust and distrust, and their current emotional state and the current state of the relationship, and all of those things impinge on mentalizing. So fortunately, again, back to John's point, with time, with effort, with practice, we can actually get better at it. And one of the most hardening areas of research is just fabulous, is work now, getting in on the ground floor with parents and infants, and really working, they videotape the interaction, they talk about it, they get, a group of parents together commenting on their observations, like our groups, where you get the use of mentalizing power of the group, and you start looking at pain. This is where mindfulness comes in, being more mindfully attentive to what's going on, and it actually makes a difference. It moves kids into more secure attachment, and obviously it's very helpful for the parents. So it's all common sense, but there's a lot of good science, thousands, literally thousands of studies on attachment that bolster this, not so much on mentalizing. There's an irony. The best study that therapy improves mentalizing and the security of attachment does not come from mentalization-based therapy. It comes from transference-focused therapy. So this is the fact that these good therapies, and again, validation. This is validation, being tuned into what the other person is experiencing. The other piece of it, and this is in DBT and it's in MBT, is we don't just validate, we have to challenge also. We have to say that, okay, yes, okay, I understand where you're coming from, but I see things differently. So that's the dance that we do in DBT and MBT. And I see, my sense is that I don't know how it's going to come across. I think Linehan is a genius because she figured this stuff out before the attachment research really made it clear. So I see these things, we're talking about emotional dysregulation and invalidation. So we're talking about the same thing. It's mentalizing in our language. But we really are talking about the same thing. And this is why all this stuff works with the ethic of goodwill. So I have filibustered.
Wow. Well, we're at Menninger, and we've been with Menninger. Thank you so much. I think, yes, questions. If you have questions, I want you to input them. I think you all have my email address, and if you don't, you have Dr. Karen Hall's. If you have some questions, and I'm sure Dr. Allen will be glad to kind of fill in the blank spots. But I thank the two of you for an absolutely excellent morning. I've been so impressed and enjoying it. Now, speaking of enjoyment, this is